Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
There is a moment in medicine that most patients never remember. It happens after the IV is started, after the consent is signed, after the monitors begin their steady rhythm. The anesthesiologist leans in and says, "Take a few deep breaths." The room softens, the lights blur, and voices fade. And then the patient disappears into anesthesia. From that moment forward, their life is no longer in their own hands. It belongs entirely to the people standing over them. Surgery is one of the most profound acts of trust a human being can make. We rarely question that trust because modern medicine has earned it. But today's story asks a question that is deeply uncomfortable for healthcare providers. What happens when the system designed to protect patients fails to recognize danger, even when that danger is inside the operating room? This is the story of Christopher Duntsch. Some describe him as confident, some called him brilliant. History would remember him differently. Dr. Death. And while this story takes place largely inside hospitals, make no mistake, this is an EMS story too. Because when healthcare fails, we inherit the fallout.
Before we begin, we want to set the tone for this episode. This is not sensational. It's not entertainment. Every patient we discuss trusted the healthcare system and expected to be made better. Instead, many left permanently harmed.
And in this episode is not about creating fear of medicine. It is about sharpening clinical awareness. Because the patients harmed in this case did not disappear. They became 911 calls, emergency department patients, critical care transports. They became someone else's responsibility, sometimes ours.
To understand how something like this happens, we have to begin with the simple truth. Medicine does not allow just anyone to become a neurosurgeon. Neurosurgery is one of the longest and most demanding training pathways in healthcare. 4 years of medical school, 7 or more years of residency, thousands of hours in the operating room. Residents are evaluated relentlessly. Technical precision, decision-making under pressure, anatomical mastery. The margins for error are measured in millimeters, because the structures they operate on, brain and spinal cord, do not forgive mistakes. So, when Christopher Duntsch completed his training at the University of Tennessee, an implicit message followed him to his practice. This physician is safe to operate. Hospitals depend heavily on the assumption patients never see the credentialing meetings. They see a white coat, confidence, the promise of relief, and they consent.
When Duntsch began practicing in Texas in the early 2010s, nothing outward suggested what was coming. He spoke about innovation, about building a modern spine practice. Patients arrived seeking answers for chronic pain that had stolen sleep, mobility, careers, independence. Spine surgery often represents hope when conservative treatments have failed. Patients don't enter those operating rooms casually. They enter because they believe surgery will give them their life back.
Every surgeon has complications. Medicine accepts that risk is inseparable from intervention. But what defines safe practice is not perfection, it's pattern. And early in Duntsch's surgical career, patterns began to emerge that troubled colleagues. One patient underwent cervical spine surgery intended to relieve pressure on nerves. Instead, post-operative imaging revealed hardware positioned in a manner inconsistent with safe anatomy. The patient woke with profound neurological injury. Permanent.
It's so crazy to me that, like, how can you be that bad at something so serious?
Mm-hmm.
That's terrifying. And another patient entered surgery able to walk independently. After the procedure, they could not stand. Let's pause there. Walking is not a minor baseline. It's independence, autonomy, identity. And in a matter of hours, it was gone. Corrective surgery was required, not for disease progression, but to repair damage caused during the first operation. When outcomes like this occur once, medicine investigates. When they occur repeatedly, medicine must act, but systems do not always move quickly.
Operating rooms develop intuition long before formal reviews occur. Scrub nurses memorize surgical flow. Anesthesiologists track physiology second by second. Techs anticipate instruments before they are requested. When that rhythm breaks, people notice. Some staff later described unease during Dr. Death's procedures, surgeries that felt disorganized, difficulty identifying anatomy, unexpected technical decisions. None of these alone proved incompetence, but together they form a signal.
During one operation, Dr. Death encountered significant bleeding. Bleeding is not unusual in a spinal surgery. Failure to control it is. Witnesses described escalating difficulty stabilizing the operative field. Visualization became compromised. Anatomical orientation appeared uncertain. The patient did not survive. Every intraoperative death triggers review, but review only works when concerns are clearly documented and escalated. Documentation determines what the future is able to see.
That's crazy to me that, like, or how often his patients were dying of spinal surgery.
Yeah.
Oh, and he
Why are you
stayed a
dying of-
doctor.
Yes.
Mhm.
He just kept
A surgeon.
doctoring.
Mm-hmm.
Ugh.
They weren't like, let me see your scalpel. They're like, keep doing it.
And they're like, well, it's not your fault.
Yep.
The spinal cord is unforgiving tissue. Compression, measured in millimeters, can eliminate motor function. A misplaced screw can permanently sever neural pathways. A post-operative hematoma can suffocate the cord before symptoms are recognized. There is no room for approximation, which is why repeated catastrophic neurological outcomes demand urgent scrutiny, not suspicion, scrutiny.
Hospitals operate at the intersection of medicine, law, and finance. Restricting a surgeon's privileges can trigger lawsuits. Reporting a physician can expose institutional liability. Credentialing failures can damage reputation. None of these pressures justify delay, but they do help explain it. Sometimes institutions choose what appears to be the least disruptive path, allow resignation. But resignation carries risk, because a physician who resigns quickly may seek privileges elsewhere, and the next hospital may never see the warning signs.
As Dr. Death moved between facilities, the pattern followed him. More devastating outcomes, more neurological injuries, more patients requiring corrective surgery. By the time the scope became undeniable, over 30 patients had been harmed, some permanently disabled, some living with chronic pain, and some dead.
Let's bring this directly into our world, because it is very easy for EMS providers to create psychological distance from hospital stories. To think, that's surgery, that's not my lane. But every failure in healthcare eventually becomes someone else's patient, often ours. Think about how many times you responded to recent surgery, now short of breath, or post-op patient with fever, new weakness, uncontrolled pain. Those calls, they happen every day, and they carry a dangerous cognitive trap. We assume safety because healthcare was already involved. But prior care is not proof of current stability. Sometimes it is the very reason the patient is in danger.
One of the most dangerous cognitive errors in medicine is authority bias. It happens when we unconsciously assume that decisions made by someone higher in the medical hierarchy must be correct. The surgeon discharged them, must be fine. The hospital evaluated them, must be expected. But medicine does not operate on assumption. It operates on assessment, your assessment.
EMS has something uniquely powerful: objectivity. You are not defending a diagnosis. You are not projecting a surgical plan. You walk into the patient's reality and ask one question: what is happening right now? That neutrality saves lives.
Normal recovery does not include rapid decline. It does not include new neurological deficits, sudden weakness, hypotension, altered mental status, respiratory distress. When something changes quickly, your suspicion should rise immediately.
Patient advocacy is not a personality trait. It is a clinical responsibility. If your assessment does not match the story, escalate. Call early, communicate clearly, upgrade transport if needed. Do not soften your language to avoid discomfort. Medicine respects clarity. You just secured the tube on a difficult airway. Can you prove it? Intublade can. Built by a combat medic turned ER physician who knows what it's like to be questioned after a tough call. No upfront cost, no capital expenditure, just affordable, single-use blades that connect to the smart devices you already have. Every intubation records automatically and uploads to secure cloud storage on our free app. Capture an airway confirmation photo if you need it, generate a secure link, and then paste it into your patient record. Done. Medical directors get a dashboard that tracks every airway across the agency. First pass success rates, performance by provider, field calls separated from training. No more flying blind on QA. No more he said, she said. Just verified proof of what actually happened. Battery free, always ready. Built by providers, for providers. Intublade.com, because your mission is clear.
After extensive investigation, prosecutors pursued a rare path: criminal charges. In 2017, Christopher was convicted of injury to an elderly patient. He was sentenced to life in prison. One of the few physicians in U.S. history to criminally be prosecuted for conduct inside an operating room. The verdict carried a message beyond one surgeon. Professional status does not place a provider beyond accountability. I think that's so, it's such a big thing right now, but, the fact that he really is one of the few, and we have, just because someone has a higher license than you does not mean that they are a sound provider.
We have witnessed physicians make terrible decisions that people have died because of.
Absolutely, and just remember that.
And they're chilling.
It's hard, but speak up, right?
Mm-hmm.
Healthcare is grounded in 4 ethical pillars: autonomy, beneficence, non-malfeasance, and justice. But ethics are not abstract philosophy. They are operational. They live in the reporting system, in peer review, in credentialing decisions, and sometimes in the courage to say, something is wrong.
The physicians who ultimately reported Dr. Death demonstrated moral courage, because speaking up carries risk, professional risk, legal risk, and social risk, but silence carries a greater one: patient harm.
We didn't dive super deeply into this case because there's not a ton of public records that I could find, essentially, but I think it's a really important case to discuss and to review, just because it carries so many things that are so prevalent to us in the field and that we probably have all already experienced, and that is that we have encountered someone with a higher license that was doing something wrong and that we knew it. And then what did we do? There's been plenty of times that I've kept my mouth shut because I was way too, nervous or anxious about speaking up. But the only reason that Dr. Death was, convicted was because there were providers, nurses, and things like that who blew the whistle. But for a long time, a couple dozen people, and nobody said anything.
Different systems, I'm assuming different regions.
Well, and what's wild is that multiple hospitals, multiple facilities where conduct is unbecoming of a neurosurgeon, resign.
Yeah.
Instead of actually pursuing taking his medical license or doing anything else, they were just oh, get out of our legality. We don't want you to be a liability for us, instead of actually protecting patients. And that's why big hospital corporations irritate me so much, because that is their concern. Is the bottom line is financial. And so they're oh, well, you're a liability, so get out.
Which
we
is
don't care
so
if you
bizarre to
kill a
me.
bunch of people somewhere else. We just don't want you to do it here.
Yeah.
Newsflash, if you kill them, they can't be a repeat customer.
Yeah, which is bad business model.
I'm just saying.
Bad.
But like
business
truly, like
model.
it is so hard. And I don't know if it's just our culture, but like it is so hard to speak up for what's right.
Mhm.
Especially like what if your partner has been doing this longer than you and they have a higher license?
Oh yeah.
Or like I don't know. It's just because this is just a good reminder that just because someone is higher license than you, just because someone seems intimidating to you doesn't mean they have all the answers.
Yeah. Yeah, and there's a difference between disagreeing with someone's care and seeing them do actual harm to a human.
Yeah.
And he was very far past that stepping point. But it is, like, I get it, like surgical nurses, scrub nurses, anesthesiologists, like he is the expert in the room. Like he is the neurosurgeon.
And then you start second guessing yourself. Well, like maybe I'm wrong. Maybe
Mhm.
he's just having bad luck, and these are just
yeah.
you know, a string of really complicated cases, and
right.
maybe I'm reading into it. That's how I would be.
What I'm super interested about is like how did he make it through all of the things he had to make it through, like residency, fellowship, like all of that. Like did he make a conscious decision to just start killing people?
Why does someone make it through their preceptorship who shouldn't?
Oh, you're right. But I just feel like neurosurgery, like that's like 15 years of people staring at you being like,
I mean,
that
it's
was
true,
wrong.
but think about people are so. I mean, we've all experienced this in this field. You're like, why is that person still employed here?
mm-hmm.
Because like,
Yeah.
it's just insane. Like, we just have to hold the line. And
Yeah.
we talk about that on the show. Like, you have to hold the line. You have to do the scary thing and stand
Yeah.
up for what's right.
You're right. And if that mentality does go all the way up into all of the systems, then there's probably plenty of people that overlooked unsafe practices from
Yeah.
him that just pushed him along. Yeah.
And, I mean, they could have taught him those unsafe practices
True.
for all we know. So, bringing this back to the EMS side of things, how should we approach this if we'll get to the doctor part in a minute, but what if we talk about just like on the truck with your partner? Like,
Yeah.
you're with somebody who makes a bad decision and they have a higher license than you. What do you do?
I think that medicine is unique in the way that, and I think that this plays into the reason why maybe he was able to do the things he was doing for so long, is that you feel like a lot of the times you cannot speak up about an injustice unless you have all the answers. Like, I know that is wrong because you should be doing X, Y, and Z. And if you don't have that, it's hard to, you always have to explain yourself. And
Like
it's
maybe
hard to
they know
justify.
something I don't know.
Yeah.
Correct. So you
Mhm.
always second guess yourself, and then medicine in whatever world is always paired in levels, right? Like even in a doctor's office, you have a physician, you have nurses. In an operating room, you have physician, anesthesiologist, nurses. And there is very rarely a place where there are multiple of the same level in one room where you actually have the ability to combat that. Even on an ambulance, like there are double medic trucks, but especially nationally, a lot of the time it is medic EMT, and it's only you two in there. So it is hard as somebody that has a lower level of licensure to look at somebody that you know knows more things than you, and to be like, you are wrong, and I can't lay it out for you exactly, but I just know that you're wrong. So I would challenge that you don't always necessarily have to have the answer. I know medicine always feels like that, but if you morally know that something wrong is happening, you don't have to always come prepared with an answer.
Yeah. And with that, because you're not always going to have all of the answers, phrasing, like the way that you say something is really important. So we figured out like a hack with PD when they are like really just like not letting us do what we need to do, or they're harassing our patient or whatever it is. We figured out a hack where we say, you are impeding medical care. That is a phrase. That's something that they know they are not allowed to do.
Yeah.
And so instead of like, you're making my job harder, get out of my way, like we say the phrase, you are impeding medical care. And they will immediately remove themselves from whatever situation you're in. And that is because of phrasing. I could have said it 1,000 different ways, but that works. And so with a situation like this, where maybe you are not the highest licensed provider on the truck or in the ED or wherever it is that you work, sometimes your phrasing matters so much, where you say, I feel that is a dangerous intervention. instead of, I think you're wrong. You say, that feels dangerous. Can we stop and talk about it for a minute?
And they might be really mean to you.
They might be. They
And
might be.
that's okay.
But you have to be willing to like take that risk. And if you use the word dangerous intervention, that phrase, if you say, I believe this is negligent, if you use the word negligent, it gets people's attention and it immediately makes them rethink what they're doing. Now, you may have to pay for it.
Yeah.
Absolutely. I'm not saying this is like you're going to come out scot-free because you did the right thing. A lot of times doing the right thing is way harder than doing the wrong thing.
Almost always.
But if you use really like token phrasing, people don't walk away from that.
Yeah.
Yeah.
You know, like if you just say, hey, buddy, I think you're wrong, they'll be like, you can screw yourself.
Yeah, I think you're wrong.
There's a lot of ego in medicine.
There is. But if you
And
say, hey, this
absolutely.
intervention is negligent, please do not do this, that is way different.
Yeah.
And it's okay to have to escalate it, right? Like, you've
Mhm.
said your piece. What happened, happened. Write the incident report.
Yep.
Go to your supervisor. And you might have to do it more than once
Yeah,
before something's done. And that sucks, but you do have a
Mhm.
duty to protect. And
for
I've
sure.
stayed silent before, too.
Mm-hmm.
Like,
Yeah.
Absolutely. And I have a hard time with people like not liking me. Like, I want you to be my friend.
yeah, don't be mad at me.
I don't want people to be mad at me. But I've had to learn that like if a provider is intentionally being negligent or they are intentionally doing something dangerous and are not interested in correcting it, it's not an oversight. It's not something that they just missed. Like, they don't care. I don't really want to be friends with them.
Yeah.
Like, I'm good if they don't like
That's
me.
a good point.
It took
That's a
me
good
a
thing
while
say.
to feel that way, to like understand that about myself.
Yeah.
But like, that is just a fear that I have. I actually don't want to be friends with them.
Yeah.
And so that helped me a lot to be able to say things and to feel good about it when I do see something that's happening and to be able to like intervene in that way.
How do you guys feel about this scenario? This is something that I just thought of, and I want to get your opinion on it. As let's say that you are an EMT working with a paramedic, and a paramedic is doing something maybe rash, maybe something that like, we're putting a CPAP on a patient that is, their mental status is quickly declining, something of that sort. I think a good bridge, or at least to not be like, don't do that, you're dumb, they're dead, or not even to be like, that is negligent in front of the patient, because sometimes that's a hard bridge, because you don't want to lose the patient's trust, but you also want to intervene.
Mm-hmm.
To you as the EMT, to the paramedic, maybe calling for a timeout to be like, can we just talk through these interventions real quick before we do anything? Because I think, and y'all, I want your opinion on this. In my brain, that would at least give the medic time, maybe if they are just doing something out of like rashness, like
Mhm.
they're just like, oh, gotta do something.
Yeah.
I think that would maybe give a moment to, if the medic was like, well, I'm doing this because, oh, yeah, you're right, their mental status is declining. Maybe we'll escalate to the next thing.
Yeah. And I think that would help, like a timeout, just being like, hey, can you walk me through why you want to do this? But also to say what you're worried about.
Yeah,
So,
I
like,
think that's really important.
Yeah, if
I'm
you've
worried
recognized that their mentation's declined, maybe your medic hasn't.
Yeah.
Maybe
or
they've
you don't
been
even have to. You just be like, oh, it looks like they're becoming very
lethargic.
obtunded.
Yeah, say,
Yeah.
hey man, I'm kind of worried about their mentation, and they might pop their head around the patient and be like, uh-oh.
Yeah.
You right.
Yeah.
Yeah.
So I think that is a good bridge to vocalize what it is that you're worried about, or have a conversation about the intervention with them first before you have to use
Big language.
hard words. Yeah.
I think that's why it's so important to emphasize that, like, we are a team.
Mm-hmm.
Like, licensure matters, but, like, at the end of the day, we're a team. Just like Dr. Death and his team. Like, at the end of the day, we are a team, and that should be your priority. Like,
Mhm.
everyone's role in the team, not everyone's level in the
Yeah.
team. Like, just because you're an EMT does not mean you
Oh, yeah.
can't be assessing the patient, be providing, intel on this patient that is helpful to your provider or your paramedic partner. Like, you're still a provider, and if this paramedic was not here and you had two patients, like, you would be doing the same thing. I think we have, like, this mentality or, like, this culture of, like, you're nothing if you're an EMT.
I
Yeah.
agree. Like, when Obs was an EMT before she got her medic, she saved my ass so many times by just noticing things.
Yeah.
Being like, hey, this patient has X, Y, and Z going on, or I noticed this, or they are missing a leg. Like, just
Yeah.
stuff.
I found it
Um,
over there.
Hey, there's
Yeah.
a needle in here.
Right? But, like, she saved my ass so many times just by noticing things and communicating those. But if we weren't a team, then I would not have known those things because she would not have said anything because she would have been like, well, I'm just an EMT.
Yeah.
But that was not the case. And so it is so important to be in a partnership where it is truly a partnership.
And do you not think that if, I guess, the system didn't view it as like you're a team, they wouldn't just hire some random person to be a driver who they didn't have to pay more because they don't have a license?
100%.
They would definitely do that.
They would totally do that.
They would just hire a driver.
Some places do that.
Yes, they would absolutely be like, you're on your own.
Yes,
Mhm.
it is valuable to have another provider.
It is.
Absolutely.
It's necessary. Checks and balances.
Yeah, regardless of licensure, it is valuable to have another person just looking at the same stuff you're looking at
Yeah.
to make sure everything's going well and is kosher.
You're a human. You're going to miss stuff. We're not scanning like AI. Even AI is
Mhm.
going to miss stuff. Like, I think that's a lot of responsibility to put on yourself if you're one of those medics who's like, I am the only person who can make any decisions or have any input.
Right.
That's wild.
And
Yeah.
odds are, if you're listening to this podcast, you are not that medic.
Yeah.
Most
people aren't.
If you
They do
are,
exist.
though, I challenge you to make your EMT your partner and not just your EMT. And if you are in a situation where you are the EMT in that partnership, speak up. The more you say useful things, it may
I mean,
It may
think
change their mind.
about the first time you got put in the back as an EMT with something you should not have been put in the back with. That's
Mhm.
terrible.
Mm-hmm.
And because of that, I never want to make an EMT feel like that. But I also remember the first time I said no.
Yeah.
Mhm.
And I was right. I couldn't have been more right. This was so bad. But like that was like he never apologized to me. He never said anything to me after
Yeah.
that. And there was never a problem after that. But sometimes you just need to do it one time to be like, okay,
Yeah.
I can do it. And I hear this a lot. It's like, well, it comes down to the paramedic's license. You are going to get drug into this, first of all.
Mhm.
Secondly, why would you put yourself through that? If
Yeah.
it is up to their license, it's not you protecting them, it's you protecting yourself.
For sure.
Not only legally, but also just like emotionally.
Yeah.
You should not
Yeah.
be writing with things that you don't know how to fix or
100%.
aren't prepared to.
And that's like my biggest thing when medics put EMTs with calls that they shouldn't be riding with, that should be ALS. The logic, I'm not going to do anything, so you can ride with it. Like, I hate that. Mostly just because it puts them in a really hard position.
Yeah.
If anything changes, they are basically faced with doing something that their service doesn't allow them to do, or just staring at this patient while they decline. Like, you just put them in a terrible position. And
Everybody
regardless of if there's any like punishment via licensure that comes from that, honestly, to me is like a moot point,
Yeah.
because what you've put them through emotionally is so much worse.
Yeah.
Yeah, that's selfish.
Yeah, it's just not cool.
It's selfish. And I think that's what was happening in this case. People were just like, I don't know if it became like monotonous and it just became like routine to just like, this is what we deal with. Maybe he was like a terrible bully. I don't know. But there's lots of factors that can keep us from speaking up, right?
Or maybe
Like,
he was super, super nice.
yeah, that would be even worse. I mean, people did say he was charming and he was confident.
And he may
Yeah.
have been able to for a long time until the pattern became too egregious to ignore.
Yeah.
He may have been able to explain a lot of it away.
Yeah.
Or he was like, oh, yeah, well, this is what happened, and I saw this.
The
and-
IV rolled.
Right, and I've seen so many
The vein
medics
rolled,
do that
not
too.
the IV.
Like where their ego's in the way, where you confront a medic after like a code or whatever it is, and you're like, hey man, so like this didn't go super well, like what were you thinking here? Like you got your airway before you even give epi, like that's not the right order.
Yeah.
What's up? And they're like, oh well, I was concerned for XYZ reason, and they'll explain it all away instead of just taking accountability for it.
Yeah.
And for a second it makes you be like,
They
huh.
gaslight you.
Yeah, you're like, well maybe it is okay that you did those things.
Yeah.
And if he was really good at doing that,
Kind of sounds like he was. That's
Yeah.
how
Yeah.
he's described, competent and charming. I mean,
mm-hmm.
and that's even more sinister.
That's probably how he got so far.
Yeah, absolutely.
Yeah.
What would you do if you needed to, before we close things out? I'm sorry, I know that we've gone on a rant, guys. But lastly, what if you have the situation where there is someone who is not affiliated with your agency maybe, and it is like a hospital personnel or something who is maybe a doctor with a much higher license level than you? Like, how would you approach that? For me, it's hard. I mean, that's hard.
Mhm.
Like, maybe I do know I don't know what's going on in this situation. Maybe I don't have all the facts. But I think we all in this room have been in a situation where immediately, as soon as you try to hand over care, they're dismissive of everything you say.
Mm-hmm.
Then they do something that harms the patient because they order something or they, write it off or whatever is happening. In those situations, how are we going to handle that?
I don't know what is necessarily the best way to handle it. I can tell you how I handle it.
Yeah.
I'm very blunt and very direct. We have had plenty of issues in different facilities we've gone to where they will start immediately DCing all of your interventions that you've initiated.
Yeah.
And our most recent one was a norepi drip.
I think that's a pretty global problem that people face too.
And they just started just DCing everything, and they DC'd the norepi drip. And I told them, I said, if you DC that patient is going to decline. Like, they're going to code again. Don't DC that.
Please don't.
And they did again. And I said, get ready to work a code. And so I'm just very direct.
Yeah.
And then they did work a code because exactly what I was concerned about happened.
Yeah.
And in a situation where you're in where like you have residents or whatever it is, like I'm just vocal. It does not always fix the situation, but I make sure that they know that that's my concern.
Yeah.
Yeah, there's not a great way to fix it. In situations where, like in that situation, like I talked to my captain about it and we brought it to our education director so that they could train the hospital, do not DC interventions prior to even knowing what's wrong with this patient. They do the same thing with like pacing pads.
Yes.
They'll just rip your pads off while you're pacing. Right. And so I think you have to be vocal and you have to either stop that from happening or be very vocal at your displeasure of that happening.
It just sucks. It sucks so bad.
It's hard to do.
Yeah, it is hard to do. I think it's something that gets easier the more time you've been doing it.
And sometimes they look at you like you're just throwing a tantrum.
Yeah, but
because
you're about
they'll be
to kill them.
I'm like, no, you're murdering them.
And we have you may have not experienced, because we drop off, right, to a million different people. Like us bringing you a patient who's being paced, but we've brought in a million patients who've been paced. We know what is going to happen when you stop that. We know what was happening in the back of the truck before we started that.
Correct.
Like, I think the best way is education. I think you're right. Like, informing your education director. Hopefully they have a good enough working relationship with someone at the hospital where they can communicate this. I mean, it sometimes feels like an uphill battle. You're just going to keep fighting it.
Yeah. And thinking about it, I think sometimes the best way to address it is to try to stave that off before it ever even happens.
Yeah.
And so, like, what we've done before that's been helpful, that we forget to do on every call, but when we get there is start basically saying what you're going to do. Like, I'm going to keep the patient on our monitor until you get your monitor. Our pump is going on your pole. Let me know when you're ready to switch that.
Yeah.
Like, we've just started saying what we are going to do. So the positive action is not DCing those interventions.
Yeah.
And I feel like that's helped a little bit.
Yeah.
If you are, delivering to a facility that will listen enough.
Yeah. Sometimes I don't.
Sometimes I don't. But I think the moral of the story is don't trust blindly.
Yeah.
And trust your gut because it's telling you something.
Yeah, you're probably right.
Pattern recognition. It's a thing.
And we're very good at it.
Absolutely.
We are very good at it. I think at the end of the day, half of our job is patient advocacy. We're like the only system that finds people where they are and takes them to definitive care. And it's your job to paint the picture from point A to point B. And I think that as long as you are advocating for your patient fervently, there's only so much that you can do up to the point in getting a fist fight with a doctor, which, let me tell you, does not help anybody.
Are you speaking from experience?
Yeah, you know me on the streets. I just be. Anyway, moving along. So at that point, you speak your piece about everything that you feel that you need to advocate for your patient up until the point where you can no longer do so. You are completely shut down or whatever the case may be. Pretty much right up into getting in a fist fight. That's really where the line should be, for sure. And then it is your responsibility from there to escalate that up the chain and hopefully get some positive change in the way of education or facility relationships or whatever it may be. But just remember that there's only so much you can do. And at the end of the day, as long as you are advocating for your patient the way that you know you should, then
do what's right.
You cannot fix the entire system.
For sure.
It's not up to you to fix the system right there in the ambulance bay.
No. And I think what we've adopted is to be pesky with a purpose.
Yeah.
I like it.
You know, people really, they just want you to stop being pesky. So a lot of times they'll fix whatever they need to fix. So you'll quit being pesky.
That's true. They don't want to hear it anymore.
Yeah.
Patients trust the system, but the system is not a building. It is people. The nurse who questions, the physician who reports, the paramedic who reassesses, the provider who refuses to ignore a pattern. Never let hierarchy override your judgment. Never let reassurance replace assessment. And never forget, you are not just EMS. You are a licensed medical professional standing at the front line of patient safety. Sometimes the difference between harm and rescue is the clinician willing to ask one more question.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.